The lights here. The group I work with comprises myself, Alison Clark, Andy Molyneux, Mary Sneed, Julia Yarnold, although she retired 2 years ago now. And this group has really come to the end of its useful life. But having said that, I hope in the next half an hour or so I can show you that it has made a difference, and it's that work that I hope this session will showcase. My title, a flow disruptor. Well, this is a flow disruptor. It's a bag of woven nitinol wire which is used to treat intracranial aneurysms. But I won't spoil the surprise, only to say that ONRU, as it still exists, is continuing to do research as the core lab for a series of clinical trials working on or demonstrating the usefulness, efficacy, and safety of this device in the treatment of intracranial aneurysms. And that repertoire of trials will continue over the next 3 to 5 years. It's produced a substantial number of papers so far, and I suspect that it will go on producing papers over the next 2 to 3 years. What it represents is some work that started quite a long time ago, and it is one arm in a strategy to manage intracranial aneurysms via the endovascular route. And that's a process that I'd just like to go back through the history of for a few minutes. The diagnosis of intracranial aneurysms, of course, was impossible in vivo until we had cerebral angiography. So this man, Igor Monez, a Portuguese neurosurgeon who won the Nobel Prize, not for inventing cerebral angiography, but for describing frontal lobotomy. He was also apparently foreign minister for Portugal in the 1930s. But a clear polymath, and with the introduction of cerebral angiography, we had the potential of diagnosing intracranial aneurysms. That meant that we had the potential of performing direct operations, and the first direct operation for an aneurysm was an anterior communicating artery aneurysm, which was wrapped with muscle by Norman Dott in Edinburgh in 1933. The introduction of clipping followed very quickly, and the pioneer for that was Walter Dandy, and it followed 5 years later. And that's really how things stood for the next 50 years. Clipping became the frontline treatment for intracranial aneurysms, and it failed to address the problem this image demonstrates. And what this image is, it's a dissection of the circle of Willis, or the vessels of the circle of Willis, which has been very painstakingly made to preserve the perforating arteries that arise from the vessels that form the circle of Willis. And then it's been photographed with the specimen immersed in fluid, so that you can see all these small vessels. I wonder if I point it up. For instance, we can see Huberner here, which always was a target for the surgical clip when the neurosurgeon was operating down a dark hole from the other side. If he caught Huberner, he would cause a hemiparesis. So dissection in this area was fiendishly difficult, and that was apparent quite early on to a series of pioneer neurosurgeons in the US principally, who attempted to use the endovascular route to seal aneurysms. In other words, the objective to isolate the aneurysm sac from the circulation and not to cause disruption of the parent arteries. Now, there were some other attempts, but the first real attempt to address this problem was by a Russian, Fedor Serbyanenko, working in Moscow in the 1970s, who introduced balloons, or detachable balloons, which could be placed in the artery adjacent to the aneurysm, seal the artery, very much in the same way as neurosurgery was doing proximal ligation of the internal or external carotid artery in order to cure cavernous aneurysms. And you can see what this illustration shows. Here's a balloon, here's the cavernous aneurysm, and having the benefit of controlled angiography to demonstrate collateral flow from the circle of Willis, he was able to cure cavernous aneurysms by occluding the artery, and that was an effective treatment for aneurysms that occurred below the level of the circle of Willis, so you could rely on the collaterals. Here's another example from our practice. You can see the aneurysm here on MRI, occlude the internal carotid artery on the left side, control from the right side to show that there is collateral support, and wait 6 months, and the aneurysm disappears because the flow within the aneurysm has been stopped. Well, the logical extension of that was, well, can we put the balloons in the aneurysms? In other words, isolate the aneurysm by putting the balloon in the aneurysm. And again, you can see the problem. The balloon has got to match the exact size of the aneurysm sac. So here you see 3 balloons in an aneurysm, but the spaces between them is still subject to the flow of blood from the parent artery. So can you put the balloon just in the aneurysm, into a small aneurysm? Well, yes. But it was fiendishly difficult, particularly because of the techniques of imaging that we had in the late 1980s, early 1990s. And this is the only example of an aneurysm that I ever treated by placing a balloon within the sac. The other problem that emerged from this work was that balloons were very stiff, and even when placed accurately like this, the aneurysms tended to recur or rebleed. To address this, people said, well, instead of putting in balloons, let's put in coils. And coils represented a length of wire that could be threaded through a catheter and then coiled up because it was given a memory before it was introduced. The problem with them, you just push them through, and once they came out the end of the catheter, you had no control until Guido Guglielmi came along. And what Guido Guglielmi, a neurosurgeon from Italy, working in Los Angeles, developed was a device that had controlled detachment. And that was the big step. So it allowed us to put something into the aneurysm when we knew it was in safe position, press a button, and it detached. What we see in this slide are 2 people. The one on the right is Guido Guglielmi. The one on the left is a Czech engineer who took his idea and refined it to give us the device that actually works. Guido's idea was to put the platinum wire in the aneurysm sac and apply an electric current to it to induce thrombosis. And he thought that by inducing thrombosis around the coil, he could seal the aneurysm and isolate it from the circulation. What Ivan Sepeka saw was the potential of using the current for electrolysis and to provide the controlled detachment. So you see here the coil. This is made of platinum wire, which has been given a memory. This is a control wire, which is made of steel, which is insulated up to this point, electrically insulated. And then at this point, the junction between the two, there's a short section of steel which is uninsulated. So when you apply the electric current, that electrolyzes and the thing detaches. The principle was, you put the catheter into the aneurysm, thread the wire into the aneurysm sac, and you produce a ball of wire which will baffle the blood flow and seal the aneurysm. And that's where we came along in the Radcliffe Infirmary in the early 90s. And as David said, we did the first operations in the UK, and in fact, the first operations in the EU, because we were given permissions, and we were already working with Guido and the team in Los Angeles to develop the device further and to perform training for trainees, for physicians taking up the treatment. Out of that came a series of trials in the 1990s. The landmarks, I think, were once we realized that it was safe enough to put this device in aneurysms that had recently ruptured. You can imagine when we first started, we wanted to treat aneurysms that hadn't recently ruptured or were, we knew, stable. But with the benefit of experience, we realized that the device was sufficiently soft that it could be placed safely in aneurysms that had recently ruptured. And this was obviously a big benefit for the patient, because the patient after subarachnoid hemorrhage is really in a condition where neurosurgery is not appropriate. And this is well known to neurosurgeons, and practice at that stage was pretty much divided between the surgeon who thought we must operate immediately in order to protect the patient against rebleeding, and the contra view was, let's wait 2 weeks, the patient will be in better condition, we will get better surgical results, which is absolutely true, and we'll have to accept that a small proportion of patients will bleed and probably die while we wait. So here was an option that we could do immediately without the morbidity of open craniotomy. So by 1995, it was clear to Andy and I that this was going to work in the subarachnoid hemorrhage patient, and that was the impetus to set up a randomized controlled trial. And the randomized controlled trial, ISAT, reported in 2002. Now, at that stage, the principle of the operation was demonstrated here. You put the catheter, this is a little marker that you can see on the end of the catheter on X-ray. You use fluoroscopy to place that within the aneurysm sac. You place the largest coil the aneurysm will take, and then into that coil you put more and more smaller coils in order to build up piecemeal an embolus that conforms to the shape of the aneurysm. ISAT, the prospective randomized controlled trial, was designed here in Oxford and performed by what we used to call the ISAT office, and the ISAT office morphed into ONRU. It was a pragmatic trial. It had simple primary endpoints. Was the patient who was randomized dead or alive at 2 months or at 12 months? And if they weren't dead, were they dependent or disabled? And to randomize patients, we obviously needed clinical equipoise, and the trial recruited about 20% of patients who were admitted to neurosurgical centers throughout the world after subarachnoid hemorrhage. And the secondary endpoints were how many of them rebled, what the survivor's quality of life was the treatment cost effective, and was there a neuropsychological benefit to one arm. This was recruitment. We started, looking back, incredibly early, within 2 years of first using this technology. But it wasn't until about 1997 or 8 that recruitment took off with the award of an MRC grant, which was largely down to Andy Molyneux's tenacious bombardment of them with his view that this was clearly a beneficial treatment. The calculated number of patients needed to prove the hypothesis was 3,000. The trial was stopped by the monitoring committee at just over 2,000 patients in March 2002. For me, the only surprise was that it took that long for them to stop it. There were 43 centers, 2,143 patients were randomized, balanced randomization, and as I say, recruitment was stopped in May 2002. Here's the forest plot. It was a clear win for the endovascular process on all levels. This shows you the relative risk benefit of being randomized to the endovascular arm as compared to the neurosurgical arm. You can see that some of the subgroups were quite small, but these is WFNS. That's good relative to poor grade subarachnoid hemorrhage patients. Randomization naturally, because of the requirement for equipoise, selected better patients because they had to be able to withstand neurosurgery. The benefit there was clear in the good grade patients. The poor grade patients, you can see the paradoxical effect of a small sample. So that was the effect. That was the result of ISAT, and the effect was immediate. This was the relative proportion of patients in the UK being clipped or coiled in the 6 months prior to reporting of ISAT. And about a third of patients were being coiled, 2/3 of patients were being clipped. But 6 months later, when the same centers were re-audited, the situation had changed, and the majority of patients were being coiled. So there was an immediate effect in the UK and subsequently globally. A series of high-profile papers resulted, and you can see that these have continued with the follow-up that ONRU have been diligently pursuing ever since, with the last paper published last year. The funding for the follow-up was a logical step because of the problem of an anatomical cure. And what was clear with the coils was that anatomically, the cure was not as impressive on follow-up imaging as with clipping. So a properly placed clip would completely isolate the aneurysm neck, whereas a coil would sit in the aneurysm and the neck region was still exposed to the force of blood flow in the parietal artery, and the coils would tend to compact. So over time, a neck would open, and the anatomical cure was not perfect. So the need for follow-up was imperative. And this shows you that over the 7-year period of the first full trial follow-up, the benefit in the endovascular randomized patients remained. So this was the benefit immediately in the acute period. And as you see, at the end of the follow-up period, patients are dying in both groups, but they're dying from other diseases. This is a cohort of middle-aged and elderly people, and 10 years on, we're going to see the attrition of age, and most of the deaths, in fact, being from cancer. The ISAT gave us this foundation of a research group, and with the work to continue the follow-up within the ISAT cohort, we had the possibility of applying for additional grants to address the problem of why was some of the aneurysms recurring. Could the technology be extended to the other 80% in which we didn't feel there was equipoise? Could it be used in unruptured aneurysms? And this was a project which we were a partner in with the Department of Engineering Sciences here and with 12 other centres throughout Europe. It was a project funded by the EU to look at the natural history of aneurysms. And the problem is that we know that some people develop aneurysms. Probably it's a degenerative process because they're a disease of later life. There may be a genetic propensity. And the prevalence of aneurysms, asymptomatic aneurysms, is up to 5% in some estimates. That's an awful lot of people. It means that in every aeroplane that you're sitting in, there's probably 1 or 2 people who've got an aneurysm but don't know it in a train carriage as well. The problem is that some of those patients, the aneurysm will grow, and the majority, they'll remain silent. If they grow, some of them will rupture. And the number of aneurysms relative to the prevalence that rupture is probably only 1 in 10. And that, of course, means that if it ruptures, there's a mortality and a morbidity that we could prevent if we could identify the patients from the group with aneurysms who needed treatment. And that now, we realize, could be done in some sort of endovascular process. But what attracted the EU to funding this endeavour was that if you had to treat the other 9 patients, obviously they'd be exposed to risks, and what was the benefit? So the project was an informatics project, in fact, and the idea was to develop work packages that were designed to address the question of what is the risk of having an aneurysm. If you have an aneurysm, should it be treated? And were there alternatives to direct treatment of aneurysms? Were there preventative drugs that we could give people to prevent them? And that meant using a repertoire of techniques, informatics, imaging and simulations, genomics, and bioinformatics, to try and bring those all that information together into a system of processing and integration. It was wildly optimistic. You could have decided that when you read the application, but what drove it was the idea that intracranial aneurysms is a relatively discrete medical condition with a relatively small literature, and that it was a topic that had a lot of economic consequences which could be addressed in this way. What came out of it for us? Well, our publication with the most co-authors and a collaboration with engineering sciences. And we're working with engineering scientists, we used computer flow dynamics to interrogate what was actually happening in the aneurysm sac when we put the coils in. So this was a project which was supervised by Yanis Ventikos to simulate the flow in an aneurysm before you put a coil in, and then after you put a coil in. And once you put something in the aneurysm sac, it was amazing how the flow lines changed. So we developed a technique to start to interrogate what was actually happening to cause aneurysms to grow and what was actually happening when we put the coils into them. And this was to address the problem of coils can compact. If the aneurysm's larger, the neck's wider, there's more hemodynamic stress on whatever you put in the aneurysm. And there were a series of aneurysms that were really very unsuitable for simple endovascular packing. Well, we weren't alone. Everybody was trying to solve the problem, which could be capsulated at about a 10% retreatment rate in patients who were treated with the coils. One solution was to put a balloon across the neck of the aneurysm when you're placing the coils. In other words, to pack them in as tightly as possible to produce a rigid embolus. Another was to coat the coils with something that would stabilize the clot that forms around them. And polyglycolic acid was tried and it took a long time to prove that it didn't work or only worked marginally. Engineers redesigned the coils so that they interlocked together better and formed a more stable ball. And we injected liquids to try and stabilize the coils and to prevent them compacting. None of these have solved the problem, but they have improved the technology and reduced the recurrence rate. But what was the game changer here was stents. And during the 1990s and late and early 2000s, flexible stents were introduced that could be placed in intracranial vessels. They were light, they were small, they could be passed through the carotid siphon. And they were very useful. They meant you could put a scaffold across the neck of the aneurysm to hold the coils in place. You could use them in fusiform aneurysms, where you had to preserve flow through the parent artery. You could use them for salvage, if a coil migrated out. You could use them to improve the flow in the parent artery. And it was hoped to reduce the level of recurrences. What then happened was another technological change, which was the introduction of braided stents. And braided stents are woven nitinol wire, and that provided the possibility of producing stents with much smaller holes. And much smaller holes meant a lower porosity. In other words, the stent would act more like a covered stent, which would be the ideal as something you could put across the neck of the aneurysm, but is too rigid for intracranial navigation. So braided stents were introduced by two manufacturers in the late 2000s under the name of, or the marketing name of, flow diverters. So the cartoon illustrates the principle. This is the principle demonstrated in time. One of Yanis's models that was developed to show you that the flow pattern in an aneurysm is actually very predictable. So you've got to build something across the neck here, and if you build something across the neck, this is the area that's at highest stress. And if you can calculate from these sort of experiments or simulations how small the pores are that you need, in other words, how much baffling you need across there, you can refine the design of your stent. And that was a principle that came out of the Aneurysm project. Here's another example of what happens in a simulation when you put a stent across the neck of the aneurysm. And you can see by choking the flow into the aneurysm, you gradually induce thrombosis from the margins of the sac inwards. In practice, well, here's an example, another large cavernous aneurysm. Here's the stent being placed. Here is the stent, and it's a woven stent. It's still not completely deployed. This is the start of the stent here. Here's the stent crossing the neck of the aneurysm, and here's the catheter that's delivering the stent into the artery. And once the stent's in place, you can see, if I'd shown you it to start with, but you'll have to take my word, but the residency time in the aneurysm of contrast has been increased because the stent, which sits here, is retaining the contrast. And with that in place, the expectation is that the aneurysm will clot, and you can see how that's happened. And here the blood vessel has reconstituted around the stent, which becomes absorbed in the artery wall. And over time, the MR shows you that the aneurysm will shrink and disappear. For fusiform aneurysms, this really is the only solution. These are aneurysms that occur in dysplastic sections of arteries, usually larger arteries, and by placing a stent and relining the blood vessel, you can direct blood flow away from the margins of the aneurysm and stop it increasing in size and causing neural compression. What use did flow diverters? Well, this was the current or the current situation now. They're useful for large and giant aneurysms, useful after failure of endosaccular packing, fusiform aneurysms, and for very tiny aneurysms, which are too small to hold coils because of their very sessile shape. So you can reline the blood vessel. ENRU again, we were involved in the Silk registry. It was a post-marketing surveillance and resulted in, again, a series of publications. And it was the first time that we had been engaged with a private company to provide research support, so-called core lab readings, and an independent adjudication of results. There was an explosion, technological explosion, with several companies producing these devices. They're extremely expensive and have problems. And the problems are that because you're putting so much metal into the artery, it stimulates intravascular thrombosis, and you need to give the patient large doses of antiplatelet drugs and antithrombotics. And that can cause problems. And there's a small chance that you will occlude branch arteries because the stent covers their orifices, or that the whole system will fail and the aneurysm will break down and re-bleed. So it wasn't, or hasn't been, the complete panacea. And it never would be, in the sense that a lot of aneurysms are terminal. And by that I mean they're T-shaped. So you've got a large artery here, which is the basilar artery. The aneurysm grows directly in the direction of its blood flow, and there's a major branch artery, the posterior cerebral artery is here. Well, this is a simulation of putting a stent. You make the image and then you play with the computer to put in a stent. But you couldn't put a high-density stent across here because that will block the flow into the two arteries, the posterior cerebral arteries, that you're trying to preserve. So in this situation, what do? Well, that's where we come in with the flow disruptor. And this is the web. This is the device that we're doing the core lab work for. It, as I say, it's a nitinol basket which is delivered into the aneurysm sac. So this is what it's ideally going to look like. There was an aneurysm here. Here you see a little marker on the bottom of this device. There's another one here, and there on this image you can see that so-called stem or proximal mark, and the rest of the device you can't see because it's been subtracted from the image. And this is the neck of the aneurysm, or the reconstructed neck of the aneurysm, around the proximal basket, a proximal edge of the web basket. Does it work? Well, it works in the aneurysms that it's designed to treat. Aneurysms that are at terminations, in other words, the basilar artery termination, the internal carotid artery termination, such as this, or aneurysms at bifurcations, which, if you rotate this image, you'll see is actually a termination aneurysm. It's just that it happens to be along the line of gravity, of the horizontal rather. What do? Well, the core lab work, which is now led by Alison, involves a lot of metrics that we have to report in these trials. What have we seen? Well, we've seen a lot, which we're not supposed to talk about, but it's clever. Here's the device being deployed. The delivery tube is here. There's the aneurysm sac. This is the marker. Once the device is in place, you can see that it's induced thrombosis within the web itself, but there's still contrast filling. Keep missing my, there we go. There's still contrast filling at the aneurysm neck here. If you wait 6 months, that's improved. And those are the follow-up calls that we have to make. So we grade them. You can see this would be a remnant aneurysm. This is at 6 months. You can see that this is a neck. And then at 2 years, the neck of the aneurysm is healed and the aneurysm has been cured. There are problems, as always, and it's basically boils down to sizing. If you can size the web to fit the aneurysm so that it baffles, you will occlude the sac. But if you oversize it, it will tend to compress the artery that you're trying to preserve. So it's a niche device. It's for terminal aneurysm geometry. Its stability depends on achieving this balance of sizing, and their long-term stability really needs to be proven, and that's the work we're doing. Now, to finish, I'm going to be blatantly commercial. Out of Aneurysm and the development of a collaboration with engineering sciences here, we took part in a translational grant funded by the Wellcome Trust and EPSRC as one of their major themes. And what the brief was to develop or to redesign an endovascular stent for intracranial aneurysms, which would get round the problems of the braided device with its high metal content. So that was our brief, to design something which was an effective flow diverter, didn't need to put the coils in, that could be accurately deployed and had a better or equivalent safety profile. And we wanted to take out the inherent flaws in the braided design, which is it doesn't have sufficient radial force to make sure that it impresses against the artery. So it tends to collapse, and of course that means that the artery thromboses and the patient strokes. And we wanted something which we could, initially we thought would have a uniform mesh, but there's ways of modulating. And what Wellcome gave us was a stent cutting machine, and together with Yanis Ventikos and his computer modeling, we refined our designs using this stent modeling machine to cut prototypes, working with Zong Yu, who is, I call him the professor of origami, because his expertise is in folding. And the challenge here, engineering challenge, was to fold the stent so that it could be delivered through the small tubes that you need to get into the intracranial vasculature. So over 5 years, we developed, we prototype designed, we cut prototypes, we tested them in phantoms, and then we went on to test them in experimental aneurysms. And this is an experimental aneurysm. It's placed it's the remnant of the carotid artery of a rabbit, and you can see that's the target. You place the stent across the neck of the aneurysm. There's the stent in place. And then when you re-angiogram, we wanted to see that the aneurysm was no longer filling, and it isn't. So we proved the device's efficiency in an animal model. And then what do you do? Well, you find a backer. So we have obtained the intellectual property rights, we've done the background research, we've gone out to market to get the funding, and we're now looking to the point where we can do human trials to apply for CE marking. The process has been facilitated by what was ISIS. As you can imagine, it's been renamed Oxford Innovation, the university spin-out company. We've raised £2 million. That's going to give us enough, we hope, to get to CE marking. These are the people employed. You can see there was a little press release. Mike Kareem is the chief executive. Brian Howlett, who has been chairman of a similar spin-out or company. And this is Yong Yu, who is, as I say, the master of folding. And so I leave you with a plug for Oxford Endovascular, which I hope you'll hear more of in the future. Thank you very much.